And I'm here with Dewey Howard, who's the CFO for the Institute for Community Living, who's going to be our main presenter today. And we're looking forward to having him present this webinar that's for one of our cohorts on the Billing Best Practices cohort. And Dewey, I'm going to turn it over to you.
Well, thank you, Justine, and good morning, everybody. Like Justine said, my name is Dewey Howard. I'm the CFO at the Institute for Community Living, and we're located down here in New York City. So I'm looking forward today to sharing about another 90 minutes or so and going through the billing department and going through some of the key things that we want to talk about. And we want to talk about in the context of how we do things and what best practices are and some of the elements that most billing, if not all billing departments should have, not necessarily in the order that we talk about it, but certainly the elements are important to talk a bit about. So as you see on your screen, we have the agenda. And as I said, the purpose of today's meeting is not to come up with a one-size-fits-all cookbook, list by list, checklist by checklist of what a billing department should do, but it's to give you some ideas, some concepts, and to make sure that that we've touched all the elements that we feel are in a good billing department, so that when you get together with your cohorts or you go back to your own organizations, you're able to build upon this webinar to come up with your own set of best practices, to come up with your own set of measurement tools as we do this. And today, when we look at this, we're going to talk about today's landscape. I mean, everyone on the phone has been aware that things will be changing, that everyone will be going to managed care sooner rather than later. But today, we're going to talk about where we stand in the current situation. How do we build things and what are some of the best practices today, and not necessarily address what's going to happen in the future at this point in time. So we're going to talk about the key billing and collections department best practices, or what are the best practices we should look for, what are some of the things we want to do. And as I go through this morning, I'm going to hit these in a couple of different places. So, we should be able to, at the end of the day, really have a list or have some questions that I'd be happy to answer. Department responsibilities. Well, department responsibilities are easy to assign, and we'll talk about this. Each of these key elements will have their own slide, and we'll be going through it as we further move through today's session. But department responsibilities are easy to assign. They're somewhat harder to measure, and they're somewhat harder to develop outcomes. You'll hear the word outcome today as I go through this presentation. You'll hear the word dashboard. These are very specific words that need to be defined, and they're very specific to each organization. One organization's dashboard can look very, very different than another organization's dashboard. One organization's responsibilities can look very different than another organization's responsibilities as they relate to the billing and collections department. And by the way, you notice we're talking about billings and collections here. They go hand in hand. You can do the best job in the world on billing, but if your collections don't come in, that's another story. And so we need to keep that in mind, that we're really talking about billings, and we're talking about collections, and we're talking about the barriers that are in between us trying to do a good job and trying to collect the money for the services that we've provided. We're going to talk a little bit about the department structure today. What is the structure? What are the drivers of success? So we're going to try to identify how we do things in the department, what the structures are, and what's the best way to set things up, or what's a recommended way to set things up. I don't want to say best way, because the best for some organizations may be different as we go through today. Communication systems. Communication systems are really a catch-all for being able to talk. For systems being able to talk to systems, for people being able to talk to people, for different organizations to be able to talk. When you're in the billing department, not only do you have to talk to your clinics, for example, but you may have to talk to Medicaid. You may have to talk to a managed care company. You may have to be able to do that. Your computer system, your software system, has to talk to different software systems throughout the state and throughout the country, quite honestly. And so you have to make sure that your communication systems are in place. You have to make sure that you can communicate, that the barriers to effective and good communication are identified and eliminated. regular monitoring. We're going to talk about how we monitor things. You've already heard me talk about outcomes. You've already heard me talk about dashboards. But we're going to talk a little bit about monitoring and how monitoring is not only just a got you sort of thing. Monitoring is what's done at different levels of the organization so the different levels of the organization can understand the resources that are needed to have an effective outcome. So if we're in the billing department and we're not collecting as much as we think we should or as much as somebody above the billing department thinks should be collected, is it a question of resources? Is it a question of what's being done correctly? Is it a question of what needs to be done? And that could be a decision that would be made at a higher level than the billing department. However, if we're not monitoring what we're doing, we wouldn't know whether we need more resources or whether we need something else to be done. We're going to talk about billing errors. And when I say billing errors, I don't really mean billing errors per se. Nowadays, with most softwares, when we send out a bill is usually pretty complete. There's lots of edits. There's an edit in the software side of things that says the bill's not going to leave the software unless it passes certain edits. There's an edit on the receiving side, whether you're sending it to eMedNy, whether you're sending it to a clearinghouse such as an MDON, or whether you're sending it directly to Medicare, there's an edit on both sides of that. So it's not really that. It's a question of when it hits an error code and it doesn't bill, it doesn't make it through the front door, for example, and that happens, or if it does make it through the front door and there is a denial, what's going on with that and how does that do that? One day I went through all of the error codes in Medicaid, and this was about 6 months ago, so I'm sure they've added them, but there's 450 reasons why a Medicaid claim can be denied. And that was, so you have 450 chances for them not to pay you on a simple Medicaid claim. And I'm sure the managed care companies are even getting better than that. And then we want to know where we are, benchmarking for success. Benchmarking is really, really an important tool. And what do you benchmark? It's interesting to say benchmarking. It's a great term, but what do we benchmark? And the answer is we benchmark outcomes. And so the outcomes are defined not only by the billing department and collection department, but also by the people that the billing and collection department report to. So we want to benchmark outcomes, and we want to have a clear understanding of what those outcomes are. And then, obviously, at the end of this, we've got a bunch of administrative things we want to do, because the purpose of this webinar is not, like I said, is not to give you a cookbook so you can go this way and that way, but the purpose is to set the stage so that we can have collaborations. And so we'll talk about that at the end, and we'll show you administratively what we need to do. So we have some goals, and we've talked a little bit about it. We're going to review the ideal structure of a billing and collections department. And like we said, with the ideal structure, we don't necessarily mean the ideal structure. We mean a structure that we think will really address the issues that we have before us, those of us who work in billing and collections and those of us who have billing and collections reporting to us. We're trying to let you know what are the elements that you need to be successful, okay? It's a really tough environment, okay? We're really, really in a tough environment as it goes in the not-for-profit world, and so we need to understand that. But we also need to understand that we can't do our job without the appropriate resources. So let's put that aside and let's understand that we can bring certain resources to the table, that it's really important to use those resources in a good way. So when we look at this, we want to make sure that we need to understand what are the core responsibilities of any billing department, what needs to be done, what needs to be assigned to people, and how do people know that they've been assigned these tasks to do? What's the reporting structure? And when you look at the reporting structure, is it appropriate? Does it work? Those types of questions we need to do. And key data sources, what are they? If we sat down and we made a list of our key data sources, will we know exactly what they are? Will we know all the data elements that the billing department is charged with as an intake and as an output? And do we know the barriers to obtaining the data sources? And do we know the barriers to exporting the data sources into a bill that would result in collections? Key functions. What are the functions we need to do? And so we need to ask these questions as we go through this today. So those are the things we're going to cover as we go through the slides today. And we're going to have some breaks in between presenting slides so people can ask questions as we go down through the slides. And so we'll have a little bit of a break time in between 2 or 3 slides from now, so you'll be able to ask any questions you want. You can also see what we're not going to cover today. We're not going to go into strategy implementation. That's going to be addressed, and that can be helped through the work groups. And then we also will have problem-solving calls. So we're going to have a mechanism. You'll see at the end of this webinar, we'll have a mechanism in place. So if you have a question, or if you have a question that doesn't get answered today, or if you need a follow-up question, we have the resources to provide the answers to you, or at least put you in the right direction. And of course, no webinar and no presentation of CTAC is complete without your feedback. We really, really want your feedback. You help not only yourselves with your questions, but you help the people who are also on the webinar to get information. So anytime you need to ask a question, anytime you want to give us feedback, we'd certainly be glad to hear that. And so as we go through here, if there's anything missing, please feel free to contact us on the right-hand side of your webinar screen and let us know.
Yeah, and as listed here, if there's anything from the goals above that you would like to discuss in this webinar, please take this opportunity to chat it in the box to your right, and we can make sure to incorporate in some form in the presentation today. So I'm going to give everyone a minute to chat those in, and while we do that, we're also going to go through some of these slides about who's on the line. But again, I encourage you to use the chat box if you have any questions or want any other things addressed today.
Okay. So who do we have on the line? We have the Upstate Billing and Collections cohort, and you can see the slide as well as I could read it to you. And these are folks that are there. Welcome. I hope you enjoyed the webinar today, and I hope you leave with appropriate information. And we can also see who's on the downstate side of the webinar. And there are other clinics, I believe, besides the folks we've listed here. And as Justine says, if you have any questions, feel free to ask them electronically. Thank you. Okay, so we have 7 clinics upstate, 5 clinics downstate, and you can see that Donna Perry is your upstate facilitator and your downstate facilitator is David Wozniak. And so let's take a look at those last 2 bullets. Okay, the emphasis on your ideas and collective brain trust. We're all in this together, I guess, is the best way to say that, and we really, really want your participation. We really, really value your participation, and so that's important to keep in mind as we go through today. And then Don and Jim will serve as an expert resource to help you identify further ways CTAC can help you. So please feel free to reach out to us, feel free to ask any questions, and feel free to add to this discussion.
So again, as the chat question has come up earlier, and I encourage you to use it today, is there anything I'm missing from the goals that we discussed that you'd like to discuss in this webinar? So please chat that in. And we just want to have some polling questions to get a sense from who's in the room. So Ed, if you can pull up the polling questions, all 3 will pop up next on your side panel, and if you can take some time to answer, that'd be great, and I'll just read through it. 1, is your entire core team in attendance for this webinar? We asked that because we found that some of the teams that really make an effort to attend together, we've noticed in the past that can really help to drive success to have everyone on the team oriented. We know that it's a big time commitment, however, so again, it's not something we require, but we're always curious to see if people are able to make that happen. In the same line, how many people are in the room viewing this webinar? 1, 2 to 3, 4 to 5, 6 or more. And third, who's on the line? Again, over the past 2 years of working with all of you clinics on these organizational practice initiatives, we really notice a difference when teams have different members of their team on board and have a multidisciplinary team who's addressing these issues together. So this just helps us to get a sense of who's on the line and, what the different teams people are bringing to the table. So I think we're at about a minute. So Ev, if you don't mind shutting it down, that'd be greatly appreciated. And let's see what the results are. And it always takes a little bit of a while to pop up. I always say we should have Jeopardy music at this point, but people don't seem to appreciate that idea.
I wish I could play the guitar as we're listening here.
You play the guitar?
Sure.
Oh, okay.
I could say that. You would know whether that was true or not, would you?
Yeah. So we have some results here. So it looks like there are some of you who have your entire team in the room, which is fantastic. Less of you have the team in the room, but that's okay, 44%. 31% didn't answer. And that's probably, it looks like, because most of you are watching this by yourself, but there are a couple of you, about, over 30% who have 2 to 6 people in the room, so that's fantastic. We're always excited to see that. And it looks like the people who are on the line we have a big mix of finance. 42% are finance, 22% executive and clinic leadership, a few clinicians, great for you, and then a couple support staff, so that's fantastic. And let's see. Okay, so I think with that, we're going to go on to the meat of the presentation here. And I think that, again, please continue to chat us your questions as you go through, and we will be answering them as we go. I see one that came in, and I think we'll be addressing it a little bit later, some of it, and then we can kind of certainly come back to it and kind of go more in depth.
Right. We'll have other breaks during this presentation where we'll look at the questions that you've typed in or you're chatted in, and we'll address them at that point. Again, this is just an introduction slide, and we're going to do billings and collections and best practices. So as we move to the key topics we want to cover today, and as you note, there's headings here. There's 6 large headings that we're going to go through today, and we'll have a slide and a presentation or a set of slides on each one of these. So it's really important to note, what are the billing department responsibilities? And you notice that we put in, or I put in, the responsibilities for the billing department to bill for all services delivered in the clinic. Well, that's not really true. It should say to bill and collect for all services delivered in the clinic. And the word collect and the word bill have connotations that we're billing the correct amount and we're collecting the correct amount. So not only do we get to bill and not only do we get to collect, but it should be the right amount. We should understand what we're billing for, we should understand what we're expecting to be paid for, and we should be able to set up our benchmarks accordingly. So you can see that we want to bill and collect on the billing department responsibilities. The billing department structure. We're going to have a whole presentation on the billing department structure, but really it comes down to what are the core responsibilities and what are the core responsibilities of the billing director and therefore the billers. Who's responsible to whom? And we say that whether you have somebody called a billing director or you have somebody called a supervisor for billing, whatever that title is that you use for the person in charge of all the billing, you need one person whose responsibility it is to be the billing director. That's the person who's charged with being able to say, if you go to that person, have you billed for everything that you need to bill for today? And that person should be able to say immediately yes or no. Have you collected everything you need to collect as of today? And that person should be able to say yes or no. That's where we need to go with this. And if the answer is yes, that's great. And if the answer is no, there has to be reasons, identifiable reasons why the answer is no. But it's really important to have one person in charge. And we'll go through that. When we go through that, we'll understand why. It's really important for people to know not only who they report to, but what their responsibilities are. And we'll talk a little bit about what the responsibilities are on a daily, weekly, monthly, quarterly basis. Communication is really, really important, like I said, and we'll talk a little bit about that. There's a slide on communications. But how do you know what you're doing is what the organization wants you to do? How do you know that what you're not getting in terms of information is being supplied or will be supplied? How do you know you're effectively communicating? How does finance effectively communicate with the program staff? And how does the program staff effectively communicate with finance? How do those things happen? And are you doing it the best way you could possibly do it? And that's really important. We'll talk a bit about that as we go. When I point out regular monitoring procedures, when I talk about that, I don't mean monitoring in the sense, like I said, I don't mean monitoring in the sense of, getting a speeding ticket for something. What I'm talking about is, when do you know that you're doing what you've been charged with doing as a billing department? When do you know that you need some help from the person who's monitoring the billing department? And how do you get those resources to do the job that you need to do, or the guidance that you need from the person or from the department above the billing department? And how do we track things? How do we really know what we want to do? Again, we get into the whole discussion of outcomes. What outcomes does a billing department is charged with? What outcomes is a billing department charged with is a better way to say that. And how do I know I'm attaining those outcomes? And how do I know, for example, if I have a biller, how do I know what their job description of a biller relates to on their daily, day-to-day tasks they have to do? It goes all the way down to that. And so we'll talk about how we understand that and how we put that into implementation inside of our organizations, and how we can make our organizations effective so that we keep our jobs to what we're charged with doing that are directed towards outcomes. Addressing billing errors. There's probably, like I said, there's probably very few billing errors. There's a lot of non-payment issues. So we're really going to talk about non-payment issues and how we try to fine-tune our system, or how we can address those non-payment issues. And again, outcomes. Benchmarking our outcomes. What is success, and how do we know that? And what are the pitfalls, and how are we going to use data dashboards? But the question is, what are we expected to perform to, and how do we measure that, and how do we know we're doing it better each day? And that's where we're going with this. So as we move on to the next slide, it's real easy to take a look at this. What do we mean by billings and collections? Well, collections, the cash coming through the door, is actually the lifeblood of the agency. It's the cash that's used to meet payroll. It's the cash that's used to keep the lights on. It's the cash that's used to keep us warm. That's what this is all about. This is really, really important that we understand that the billing and collections are that part of the agency that provides the cash to run the programs in the agency. Not that billing and collections are the most important thing we do. Obviously, serving our clients and serving the folks who come to us for help are the most important things we do. But how do we do that? And we do that by billing and collecting the appropriate amounts of money. And when you provide services, you're not going to be able to survive. There's lots and lots of stories out there about people who do great services and they have deficits. People who do great services and don't collect. They bill out and don't collect for the amount of money that they should be collecting. So it's really important that there's a match here, that you know what the rates are, you know what the rates are in your system, you know what you should collect, and you're out there collecting those monies. Billing is nothing more than submitting correct and timely claims for services provided. We're going to talk a little bit about the timely thing going on here. It's really important that everyone knows, and I'm sure everyone in any billing department knows, that we have the 90 days to submit the Medicaid claim. So we have that. We also have 60 days to do any resubmissions of any denials. So the clock is running from the time the service is done. There's a clock running on this. And so, like I said, Medicaid has 450 ways to deny payment. One of them is if the claim is over 90 days old, there's very few reasons that you can submit that claim in a clinic. Very, very few reasons that you can submit that claim that's over 90 days old. And quite honestly, you have to be careful. There's, of the choices of reasons, the OMIG is sitting there looking at any claim over 90 days old and will perform an audit on your clinic if you do that and disallow the revenue if in fact that claim is not valid. So be very careful with the 90-day rule, and obviously be very careful with the 60-day rule. Collections. When we look at the way that we do billings and collections, it's really important to set up standards. If you bill something out, again, we talk about the 90-day rule, which in clinics should not really be a problem because we should be billing every single week, and we'll talk a little bit about that as we go. So it shouldn't be a problem. Collections, if we do things correctly as we can, we should have a very, very good success rate of collecting what we bill. Obviously, there's issues that come up, and we'll talk about when the E&M codes change. We'll talk about DSM-5, and we'll talk about ICD-10 coming down the pike, and you can also talk about software changes and things. However, the collection should be a target. You should have a target. I'm going to bill out X number of dollars. I'm going to collect X%, and that should be sitting there each day, each week, each month, and you should know what your targets are, and you should know how well you're doing towards your targets on this. So that's what we're talking about here. And now we're going to try to give you a little walkthrough on the billing. And we're going to try some step-by-step walkthrough on the billing and see what we think are important in terms of components of any billing system. So the first thing we have to do is capture the services, obviously. Most softwares these days use a scheduling system. So you have a scheduling system in almost every clinic that has a software system, or it's either going to be within the software system or it will be some type of manual intervention. However, in this day and age, it should be in part of the software system, and the scheduling, the appointment module, should be an integral part of what the clinic uses in order to manage the front desk. That appointment information is very important. Most systems today have an appointment type, for example, so whether it's a 30-minute session with a therapist, a 45-minute session with a therapist, whether it's a medication management session, whether it's a health review session, whether it's an intake session, most appointments and most schedulers have the appointment type that goes back to that will go back to something usually called a service code, that will go back to a billing code, that will go back to a CPT code or a HCPCS code. All of these things are linked, and it's really important that you understand the linkage between these so that the bill that goes out the door is the bill that we thought would go out the door for the service that was provided. Excuse me. Once the appointment is kept, and again, there's no shows and everything else, and there has to be a system for accounting for that, but once the appointment is kept, once the therapist, and there's a whole set of seminars that we're doing that talks about, concurrent documentation and that type of thing, but once the therapist or the doc or the person entering the note that says, I did this service that was scheduled, I did it according to the rules and regulations, I am now putting my final note in, and it's approved for billing. It's done electronically in most systems these days, and the billing record is ready for billing. The clinical side of it is finished, and the billing record is ready for billing. And then what do? Like I said, we should be billing in a clinic. We should be billing weekly. There should be, you can bill daily too if you like, but most clinics will bill weekly, and you'll see the reason for that as I go through the presentation today. And the reason for that is much easier to track weekly, and it's much easier to track disparities in the billings and the collections and things like that on a week-to-week basis rather than a day-to-day basis or a month-to-month basis. So when we get the bill ready to go, and we do this weekly, we're going to send it out to the third parties. Our typical cast of characters in the third party are Medicaid, Medicaid managed care, Medicare, Medicare managed care, some of our friends, and of course some clinics still bill commercial insurance. So we need to understand where the billings go out. And then we need to set up a tracking system of how we send bills out, where they are in the system, and how do we do that. So when we go to step 3 here, we have to make sure the payor requirements are met, okay? And when we say that, when we submit a bill, we have to make sure it gets through the front door, like I said. So some of the insurance companies don't even let the bill in the front door. So you may not even see a denial because it may not go through the front door to be processed. So you have to have systems in place to deal with that. And that's a very detailed description of how that would work. But a lot of agencies will use an intermediary for billing other than Medicaid to make sure that you can track what was sent, what was accepted, and what was denied at the front door, as well as what was sent, what was accepted, and what was paid or denied after being processed. However, you need one person in charge of the whole process, like I said earlier. That is the billing supervisor. Whatever you call that person is the billing supervisor, billing manager, billing somebody who's in charge of the whole process. How much did we bill this week? That person should know. How much was rejected? That person should know. What are we doing with collections and denials? That person should know. There should be data available to that person so that person can answer those questions. The person should also be knowledgeable on what the payor is expecting. Do we need a prior approval for this set of insurances? Why am I seeing these denials? What do I do with people with Medicare, and how do I flip my Medicare payments into my Medicaid payments if I have dual eligibles, things like that? Why am I getting this denial for these particular set of clients are also something that should be addressed. What am I doing? For example, the clinics were charged with billing for foster care agency kids, so now we're billing to foster care agencies. A separate thing, is that going out? Are we being able to do that? And again, there's constant monitoring that has to happen. It really has to happen, and like I said, the crossovers are done timely and correctly so that we don't get denials, A, or B, we don't dare use the 90-day code for the risk of being audited. We also should know what our rates are in our system. What are the rates that we charge for different things, CPTs, APGs, and things like that. So it's really important to do that. I know a lot of people are having issues with the CSP rates. So if you have a CSP rate being added on, even though the COPS went away, the CSP is still there, a lot of people are having issues with CSP rates. Are we collecting that information correctly?
Dewey, can you explain a little bit more what a CSP rate is? What does CSP stand for?
It's one of those things. It's part of a comprehensive payment system. It's actually what it is. It's one of those things. If you got them, you know what they are, and if you don't got them, say thank you very much. And so CSPs are dollars that are paid through Medicaid that are used for other programs within municipalities. And so you're able to use these dollars for other programs, and you have a separate contract for CSP dollars you have to apply that you collect through your clinic rate on this. But you have to make sure it's right, and you have to make sure the APG rates are right. You have to make sure that your CPTs are loaded correctly. The next step is up-to-date insurance eligibility. Really, really important. Every single client that comes in should be able to verify their insurance on every single visit. There should be a mechanism at the front desk of the clinic, much like anyone who goes to their doctor, you have to show your insurance card. I've been to, every time I go to the doctor, whether it's, whether I was there 2 or 3 months ago, I still have to show my insurance card every time I show up. The same thing has to happen in the clinic. The insurance card has to be presented, has to be verified, either while the client is waiting to be seen or during that visit, so that at the end of the visit, you know whether the insurance is eligible or you know whether the insurance is eligible before the visit. So it should be checked. And it's up to the front desk to update the client's eligibility under the different insurance plans for the most part. This should be done at the point of contact. So it's really important that the front desk be charged, I think, with the job of entering the insurance on the system so that the insurance coverage for the client is correct, up to date, and the latest information. And by saying insurance, everyone is aware that there could be more than one insurance involved in this. So it's really important to do that. And then what we do is we can do a billing reconciliation. It's also important to do that. Who reconciles the billing to the general ledger? One of the things you don't want to get caught up in is having a year-end audit and not having a reconciliation between your billing system and your general ledger system. It's really important that this be done monthly. It's really important you know any differences between what's in your billing system for an accounts receivable, for the amount billed, for the amount of cash collected over the front desk, and what's in your general ledger. These have to be done every month, and they have to, the explanations, there's always going to be variances, I would think, and these have to be explained every single month so you don't end up with having to do this massive amount of work on any particular audit that comes up. You will also know what your differences are, and you'll see if you're being driven further away from your stated goals, from your stated outcomes. Again, it will also give you the ability to set your allowances correctly. This is not a webinar to deal with allowances, but everyone on the phone should be really clear that we're never going to collect 100% of what we bill for. And therefore, we have something called allowances. It's really important to set the correct amount of allowances that match the correct amount of billing. And that's really a finance function, but there's an allowance factor built in that we have to be very, very aware of as we go through this process. The more collections we can do, the lower the allowances and the more amount that we have for revenue in the clinic to be able to do the programmatic things that we want to do. There has to be someone reviewing non-billable collectible services and bad debts. Who is responsible for it? Is it the billing supervisor? Is it an assistant controller? Is it the controller? Who is responsible for looking at this? And it should be somebody who is necessarily outside of the billing process so that there is a question of if there's something that's not collectible, how does this happen? And it should be audited by an outside source, not your outside accountants, but there should be somebody within the organization who's not responsible for billing who can look at this and say, yes, this makes sense, or no, it doesn't make sense. Why are you writing this off? It looks like we're writing off what's going on. It's also important to understand in management there's a philosophy called a root cause analysis. And if you have write-offs, maybe you want to be doing a root cause analysis on your write-off to see if something's happening. Maybe we shouldn't be accepting things from this insurance company because they're not paying. Or maybe we're not picking up the most up-to-date information on the Medicaid card. Or maybe we're doing some other things that are going on. You know, so we should be looking at why we have not only the amount of write-offs we have, but why, doing a root cause analysis. And who's responsible for writing off the bad debts? Who accounts for them in the billing records and on the CFR? Everyone on the phone should be aware that there is a bad debt. There is a bad debt pool. Clinics just got a distribution from that if you reported it correctly on your CFR. So you should be going to the finance department and saying, okay, here's my bad debts. Are we making it to the CFR? So therefore, are we getting reimbursed? You're never reimbursed 100% of what it costs to do it, but there is a reimbursement based on that. And so, so those are some of the things we want to think about as we go through in the billing responsibility step by step. And so now we're going to give you a little bit of a break. And so we'll let you answer some questions. I'm going to turn over to Justine.
Yeah, so we want to hear from you. You know, we just walked through these 6 steps, and that, again, is this kind of overview of the different kind of responsibilities that the department should have. Do you feel like you do these steps in the clinic, and were there any steps that you do that we left out and you feel like the rest of the audience should know about? While we're waiting for your responses to come through, Dewey, I wanted to kind of ask you a question that came through earlier around one agency is trying to bring their billing back in-house because currently they contracted out, and they're curious to know names of resources in terms of establishing a billing department. So what are resources that they can go to for legal or regulatory help on these kinds of issues if they're establishing a brand new one in-house?
Great. That's a great question because it's happening more and more. We're realizing that we thought this was something that could be outsourced very easily, and we realize that that they're running the outside billing agencies are running into the same problems we're running into. For example, having qualified people do the billings, being able to track the collections, and being able to track some of the issues that our bills are creating. The way that I recommend you do that is to start with a flow chart. You should really start with a flow chart, and you should start to flow chart the process. How do you see your internal process working when it comes to billing? And once you start with that, you start with the billing department. I have to do a bill, so therefore, obviously, we need a software system. Who's in charge of the software system? And how do I know that the updates that we talked about, for example, there's probably 10 or 15 steps in the software we want to think about. But do we have the correct software in-house to do this? Who is going to be charged with doing the monthly or the weekly billings? And what resources do I need to do that? And how am I going to do that? How's the information going to flow from the clinics? And now it's flowing from the clinics, I guess, to the billing company, to the outside source. How is it going to flow to my internal department? How do I know what people to hire? How do I know how to bill on this? And the answer is you really need to start with the flow chart, and then you need to figure out what resources you need in terms of people, and you need to figure out what qualifications you need in terms of people for the clinic. And we can help you with that. There can be questions, there could be detailed questions on the types of people you need for a billing department and, suggested things like that. But it's really important that you make sure you have the appropriate resources, and then do a walkthrough. Once you do the flow chart, you just don't leave the flow chart there. Walk it through. Walk it through within the billing department, walk it through within the finance department, walk it through within the clinical department to say, this is how we think this is going to work. And so there's nothing worse than starting something and then realizing that we missed a step, or we're not doing this correctly, or we don't have the resource to do this. So you need to walk through your flow chart to make sure that you can actually do this. And then the last thing I would do is make sure that you can do some type of pro forma billing on your in-house system before you take it back from the billing service, because the reason you're leaving the billing service is you're probably not satisfied with them or you're paying too much money. However, you want to make sure that you can actually get bills out the door that will be paid. So keep them on board as you do your billing, and then if there's a problem with your billing system, or if there's a problem with the walkthrough, or if there's a problem with the deadline, you have a backup. In today's day and age, it's really, really important to have a plan A, B, and sometimes even a plan C. So make sure you've documented all this. Make sure when you have a new billing department that you brought in-house that everyone knows exactly what their job titles are, what their job description is, what they're responsible for each day, each week, and each month, and make sure that you've got the resources in place to do it, and then also make sure you've got a back door if it doesn't work.
Dewey, the steps are really helpful, and I think that it sounds like that's a really good way to kind of get your billing department started. I think, though, as I could see as personally as a non-finance person, there's so many different pieces there that I would be worried that would get left out due to all the regulatory requirements, legal requirements. Is it when you go on the OMH website to kind of find this different information? Are there specific, where if someone wanted to have someone with financial expertise, do you have a recommendation of where to look?
Usually your certified public accounting firm that's doing the audit, the annual audit, is really a good place to start. So the company that does your annual audit has to be versed in this type of billing because they're opining on it. They're saying, what you're sending out the door, whether you're sending it out internally or whether you're sending it out through a service, they're saying that's correct, and they're saying the amount of allowances you put in there are correct. They're usually a very, very good place to start to say, who should we talk to about this? And like Justine said, there's lots of websites, although you can get lost on the OMH website very, very quickly when you're doing this. But there's also software. The software companies do this all the time. You'll be hiring one software company to do this. The software company you're hiring probably does it 100 times a year. So they have a great deal of expertise. There's nothing wrong with doing an RFP and inviting in 2 or 3 different software companies, asking them all the questions you have, asking them how you do things with their software, how it interfaces to your general ledger. Using those resources, every meeting you have with a software company, you should come away with more and more knowledge of how to do things.
Great, thank you.
So do we want to do some questions, or you want me to keep going?
So I didn't have any questions come through so far. Again, I want to encourage you as we're going through for, if anything's unclear or things you want more detail on, please continue to chat them through and we'll make sure to get them answered. But in the meantime, Dewey, I think we can continue.
Okay, great. So we're going to talk a little bit about the billing department structure here. And again, we've touched on it, or I've touched on it as I've gone through. But again, it's really, really important that we know who's in charge of billing. Who is that person that's in charge of billing, and who does that person report to? You can see that we've made the recommendation that person report to the Director of Finance. The assumption here is that the Director of Finance reports directly to the CFO or to an associate CFO, somebody very high in the finance side of the world. But the person that we designate, or that you designate as being in charge of billing, should have a direct reporting responsibility, and should be the person 100% responsible for all of the billing. Very, very important. You can't have 2 people doing it. You can't have 3 people doing it. It ends up with finger pointing. So you have one person responsible. It doesn't relieve the Director of Finance, for example, of the responsibility of hitting the collection targets, because everything should be going up the organization. But it should then charge the Director of Finance with the responsibility of making sure things are working the way that they think they're working. The expectations of the department and each individual within the department should be clear. And when we say that, it's very easy to say that. It sounds great. You know, what are you doing? I'm doing billing. Okay, you got it. Thank you. I'm doing collections. I'm doing rebills today. It's very easy to say thank you very much. However, it's very, very important that you look at the job descriptions that you have, for example, for your billing manager, like we said, the person who reports to the Director of Finance. Look at that job description that should be signed off by that employee, should be in their personnel record, and look at what the tasks are that are there. Same thing for your billers. Do you have a job description for your billers? What do they do each day? You should be able to take that job description and come down with a scorecard, so to speak. Or not really a scorecard, but a checklist of what they should do each day, what they should do each week, what they should be doing each month, and what they should do each quarter, and what they do at the closing, at the end of the year. It should be a task list that's there, and they should know what's expected. And it should be well within their job description that they've signed off for in the personnel record. So it's really important that everyone knows this. So you know, as the head of the billing department, or you know as a member of the billing and collections team, who's responsible for what. You know on what day of the week they're responsible for these things, and you know on what day of the week reports are generated or dashboards are updated or refreshed, so that you can take a look to see how you did in the past. Again, the operative word here is see how we did in the past, because anything that comes up, we need to correct. Like we said, when we were dealing in the Medicaid world, we're dealing with 90 days and we're dealing with 60 days. The clock is always ticking, and it's not work days, it's calendar days, and there's a lot of vacations, holidays, and sick time that go into this. So it's really important that we understand what the expectations are. We also understand that the people should have the requisite skill set to meet the expectations. So you should understand when you hire someone for the billing department that they're able to do the task that you would assign to them. In a job interview, you can sit down and say, this is what we expect you to do. Tell me how you're going to do it, and see if they answer correctly on that. So not only having the expectations, but also making sure the skill set matches the expectations, to make sure that we constantly train people. There should be training involved in this as well, so that your folks in the billing department are up to speed on what needs to be done, and are up to speed on some of the issues you may have identified. And, you know, really hitting the next bullet here, and making sure that everyone knows what they need to do, making sure from a management perspective that we have the right people in the right place. We just wanted to throw up something before we get into communication. Just wanted to throw up a little thing here on what communication is. We put the billing department as the center here, the center of the universe here. And then these are all the places where communication has to happen. There may be even more places where communication has to happen, but like I said, communication has to happen in these ways. It's not bidirectional, it's not tridirectional, it's quintuple directional, I guess. The billing department is part of the finance department, so there's a relationship there. The billing department uses software. Who does the software talk to? How do I get the software? How does it work? Billing department has to use Medicaid, eligibility, and things like that. The billing department, besides Medicaid that you can send out directly, a lot of billing departments will use an intermediary. I just happen to put MD-ON in here. MD-ON is a decent sort of intermediary where you can submit bills and they will tell you whether it was accepted by the insurance company or by Medicare or not. They will tell you that it's being processed by the insurance company or not, and they'll tell you whether it's been paid, and they have built-in dashboards. So it's really impressive to be able just to buy your built-in dashboard so you know, for example, of all the claims you sent to Medicare, it's taking Medicare 47 days to process the claim, and you're being paid on 92% of those claims. Things like that you can get very easily from their dashboards. You can also use other denial software. There's folks out there in the market that will produce denial software. So when you're getting your remittances back electronically into your software, they can go through the back door, grab those remittances and tell you exactly why you're getting denials, set up work queues for your billing department, and track those work queues, as well as tracking the reasons for denial, which then goes back to our discussions on the root cause. It's really important the billing department make a very good relationship with the clinics, with the front desk of the clinics and the clinic staff. There's a lot of things that go back and forth. And I'm not just talking about sending emails. This is not about sending an email, you know, you didn't check this client out and therefore we're not being paid. That's not what communication is. Communication is something where you reach out to someone and you have an expectation that what you reach out for will be satisfied. They have an expectation that what you reach out for will be answered. So it's really important to understand how to do effective and appropriate communication. All of us on the phone, all of us in the webinar have seen emails and have seen email chains that go on forever. If you have to go with an issue that takes more than 2 emails, you really have to pick up the phone and call someone. There's no reason to create email chains on a bunch of stuff other than to, if you want to cover yourself. And that's not really appropriate in effective communications. So it's really important to communicate with people, to make people know what you're looking for. And they may say, we don't do that. And that's fine, because then there's another reporting relationship that goes up the chain so that the people can make sure that people who are responsible for different departments talking to one another can make sure they're responsible for breaking down the silos. In this day and age, no organization, no matter how big or how small, can afford to have silos, because all that will do will be impede good care. And remember, our purpose is not to interfere with the care. Our purpose is to make the people who deliver the care jobs easier so that they can deliver the care and we can deliver the services that we need to do for the organization. So you can see this communication. You can see that it goes in all sorts of different directions. You can see that if you wanted to look at layers of this, it would be very complex, and you can always communicate better. Every single day, one of the things I ask myself is, did I communicate effectively, and what can I do to make sure that I've communicated effectively? And I think that's really a thing to do to make sure that we don't have silos anymore. So let's talk about some of the key effective, the key communication strategies for effective billing as I move my own slide over here. And like I said, communication is not email. And again, a strong ability to communicate with other departments and entities. We just saw 5 different entities or 5 different spheres that a billing department will communicate with. There's probably a lot more than 5, and you can identify who you really need to talk to and how you do that. However, you need to make sure that you're communicating to get an effective billing system. An effective billing system, like we said earlier, is one that gets all the bills out of the system on a timely basis and one that collects the appropriate amount of money. If you notice, I'm not giving you a percentage. Each organization will have its own goals and benchmarks of what they should collect. Whether it's 97% or 92%, it depends on what your historical rate is, and you can see what effort needs to go in to collect even a higher percent. So if you have a historical goal of collecting 92% of what you bill in your clinic, you know, you should be able to measure what does 93% mean to the organization, what does 94% mean. However, you're charged as a billing department with collecting whatever the target is, whatever the goal is, whatever the outcome is that's been assigned. The people who assign the goal should understand what the resources are to be able to attain those outcomes. So that's the two-way street that we've been talking about all morning. You know that functions in the agency, like the front desk and like the providers and like the docs, can impact the billing error rate. Are they putting the right things in? Does it make sense? Are they doing things timely? Are the notes, and is the billing getting closed on a timely basis? So I said earlier that we bill on a weekly basis in the clinic, that's a very good practice to do. How do I know, or how do you know, that we're billing all the instances of service? So we had all these services delivered, we had all these visits being done, and how do we know we're billing out 100% of those services? Your software should be able to tell you that. You should have all the services that can be billed at the end of whatever week it is, not the end of the week, but whatever day you choose to bill the prior week's services for. And if you have services hung up and services not billed, you really have to understand that, and you have to have that communication with the clinic to understand why there's things that are held up and not billed. At the end of the week, if you bill, let's say you bill on Tuesday for the prior week, which is really a good day because Medicaid processes on Wednesday, so you want to get your bills in before Wednesday. If you bill on Tuesday for the prior week and you have 40% of your claims are not billable during that week, that's a problem. And that goes back to being able to communicate to the clinic to be able to say, you know, you need to do something with these claims, and to be able to communicate upwards to the reporting in the hierarchy of the finance department saying, we're not getting these claims in, and we can't do that. We should get all the claims in by the next Tuesday of the week before, for example, would be a good goal to do that. And if you're not getting all the claims in, therefore you're not billing out all the claims, your 90-day clock has already started and you're well behind the 8 ball on that. So you need to figure out why it's not being done, if it's not being done, and how do you overcome those barriers. And again, collaboration. Collaboration is the key. You know, you don't get to say, I work in the finance department, so I'm only doing finance stuff. You have to understand what goes on in the clinics, what goes on at the front desk, and you have to understand what your barriers to your goals are. Why can't I bill 100% of my claims on any given week? What are my barriers? And you should list them and work with the clinics or work with the people who are presenting those goals. Not only could it be the clinics, it could be a software glitch. The clinics may have said that we prepared 100% of the bills for billing. Why aren't you billing 100%? It could be something in the software, so then you have to work with your software company. But you should know immediately on that week why things aren't, how much is not being billed and why they're not being billed. And again, communication has to be constant. I can't read that. Oh, no. Okay. So we need a I'm sorry, we're looking at the chat over here, and it's small on a big screen. The quality control check put in place by the clinic supervisory staff. So we need to make sure that you put a quality control in place. And like I said, it needs to be something that can give you immediate feedback. So if somebody walks to the billing manager and says, how much do we bill this week? Do we bill 100% of the claims? The billing manager can say yes or no, and if it's no, why? And again, you know, set a regular time so everyone knows what's expected, so you can build in sick days, holidays, and other things that make sense for your organization. So that's what you need to do as far as that one goes, as far as communication strategies.
So Dewey, we had a question come in about your earlier remark on, you know, when clinics are setting individual collection goals for their organization, you know, example 90% or 95%. Are they assuming, if they're setting a goal of like 90, 95%, are they assuming that some percentage of contractual adjustments or percentage of services that are reimbursable because some clients may not have authorizations or active insurance?
Yeah, that's 3 questions in one. It's a great 3-question here. A couple things go on. Contractual allowances are very, very different than uncollectible amounts. Contractual allowances are usually built into a system where you're billing, let's say you're billing $200 a visit for your clinic, okay? So you're billing $200 a visit for your clinic. However, you know the APG rate for that visit is only $125, let's say, okay? So you have a built-in contractual allowance. That should be in your budget, so when you send the bill out the door, you know you're only going to collect $125. Immediately, the contractual allowance is computed and it's in the system. That's a budgeted amount, and that's a decision made by the organization how to do that. There's no control over a contractual amount within the clinic. It's really a financial decision on how your finance department wants to account for contractual allowances. Uncollectibles are completely different. You're only going to get paid a certain rate, whether you bill out $200 or not. You're only going to get paid, for example, $125. And you expect to get paid $125. Why? Because you know on the rate sheet that's exactly what it is. That's what OMH says you're going to be paid is $125 for this service. I'm obviously making the number up, but if there is a rate sheet that says $125, you expect to be paid that. If you don't collect that from either straight Medicaid or you don't collect that from Medicaid managed care, then you have an uncollectible amount. That uncollectible amount is measured, and you then measure that uncollectible amount into what your organization feels is appropriate. Because for every dollar you don't collect on an expected amount, that becomes an allowance, it becomes an uncollectible amount. When you have self-pay patients and you have a sliding scale, again, you should either be billing on the sliding scale, so if a client comes in and can only afford $50 a visit, we'll say, and you know that you bill out at $200, the difference between the $200 and the $50 would be a contractual allowance per se if you want to record it that way. However, you do expect to receive $50. That would be the billing amount at the end of the day. If the client says, I left my wallet at home, every time they come in to see the clinic staff for the next 3 months, and you've never collected the $50, that is certainly going to be written off, because if you don't get it, you know, within the first 1 or 2 visits, my sense is you won't get it, and it becomes a bad debt. That's the bad news. The good news is if it's recorded correctly, it can become somewhat of a reimbursable bad debt. So you have to parse these things out. You have to have that communication again with the folks in the finance department to understand what a contractual allowance is, and you have to have this discussion on how your budget was built. Every budget, every agency has a budget, and your budget is built on allowances, and it's built on collections, believe it or not. And so you have to have that discussion to see what your targets are.
And so, Dewey, I think kind of what you're saying, because I think what Lauren was asking too, is like basically how do these clinics afford to write off a 10% non-collections rate? And it sounds like that has to be built into your budget beforehand, and that's based on your prior kind of history of what you collected in the past.
Exactly. The goals are part of the organizational development of the budget. When the budget is developed each year, the write-off amount should be ascertained, and the uncollectible amount should be discovered, and it should be put into the budget. That's how the goal gets set. It should be set by the chief financial officer in collaboration with the person in charge of the programs and in charge, you know, and presented to the CEO as part of the budget process. When you go through and you develop your budget, that should be a discussion that will happen. So at the end of the day, the budget will be presented, and they'll say, somebody will say, you know, billing department, we expect you to collect 92%, 90%, 93%, whatever the number is, we expect you to collect that. That's your goal. And that's where it becomes important to say, okay, this is what I need to do. I've only collected, historically, this agency only collected 75%. How do I get to 90%? And that's where the people who are charged with billing, who are higher up in the organization, have to say, well, you know what, you need 7 more billers, or you need 5 more billers. We need to do this thing. We need to do that. And so you come up with a plan on how to get from where you are to your target, or you need to come up with a plan to stay at your target rate. Some clinics are already at their target rate. You know you're never going to do better than whatever XYZ is in your particular situation, and so you know you're there, but you want to make sure you stay there every single week, or you make sure longitudinally that you've hit your goal, whatever that goal or outcome is.
Thank you, Dewey. And Lauren and anyone else, if that does not completely answer your question, please chat more as we go along.
Okay. So how do we monitor that? I mean, we talked a little bit about, you know, the percentages of collections and things, but how do we do that? Somebody has to have a clear understanding of what goes on in the billing department. Somebody has to have a clear understanding of what's working and what's not working. And somebody has to know when something is, we use the term off course here, when it's off course. How do you know that? And do you know that immediately? And the answer should be yes. There should be a weekly report that goes on. So if you bill a clinic weekly, you should know what goes out the door. And so if you've been billing weekly and you've been billing for say $10,000 a week for the last 5 weeks, and all of a sudden you're billing $3,000, there's something wrong. Or if you've been able to bill 100% of your encounters and now you're billing 70% of your encounters in this particular week, what went wrong? If you billed and got through the front door for 100% of your encounters in all the other weeks, and all of a sudden you only get 50% through the front door, what's going wrong? Is it a software issue? Is it a glitch? Or what do we do about it? There's different touch points that you need to establish to make sure that at the end of the day that you're able to obtain your outcomes, that you have immediate feedback from where you are today, this week, versus where you were, versus what your budget is or what your expected outcomes are. So, and the way to do that in a clinic is to do it weekly. And we've listed some of the reports or some of the data dashboards. You can make this a data dashboard too if your software will allow you to do it. You know, how much went out? How many invoices or how many bills went out? Of everything that went out in the past, how much do we have to write off? And again, when we say, you know, how much do we have to write off or how much went out, how does that stack up to what our expectations are? Not only, here's a list of what we sent out 100 bills this week. Is that what we expected to see? So there has to be a setting of expectations that measures what we're doing versus what we expected. And if you do it on a weekly basis, if something goes wrong, it's really, really easy to fix if you do it on a weekly basis. If you do it once a month or once a quarter, you've lost. You've really lost. This is a weekly sort of checklist thing you go through. You need to have a list of the claims that were accepted and will be reimbursed. The denials need to be parsed out some way. Not only do you need to know what the denials are, but you need to know what to do with them. Who gets charged with that? How do you put your denials in a queue so that the billers can rework your denials? Those types of things. The weekly denied list, can you resubmit them or not? Are they being resubmitted on a timely basis? Again, we talk about the 60-day rule, okay? And who looks at these? You know, if we're going to present reports or we're going to do data dashboards or we're going to have all this data, who looks at them and how often do they look at them and who's responsible for doing the fix? Again, we want to do this on a week-by-week basis. We don't want to get involved in something that's a month or 2 or 3 or 4 months old. So we need to understand how to take immediate, effective, corrective action. We need to understand who we communicate with to do these things. And we need to understand if we start having problems, what's the root cause?
So we have another question that we have another kind of take breath for questions. I'm going to keep encouraging all of you to chat them in. I think that it looks like we were helpful in the last one, so hopefully we can be helpful to you in any other questions that are coming up. So do I think we can, I think we can keep on going, but please just keep using the chat box to your right with anything that comes to mind that you would like us to expand further on.
Okay, so I'm going to talk a little bit about billing errors, and again, like I said, we can call them billing errors, but they're really barriers to collection. What are our barriers to collection? And, you know, we do all the reports that we just spoke about. We'll understand why we're not collecting things. If we do a root cause analysis to our denials, do we have a specific denial code? Do we know what it is? Do we know how often it happens? We'll be able to take a look at it. We'll be able to figure out who's responsible for it and be able to work with that person to make sure we've done our corrective action. We should all know what our major denial codes are. Why are we getting denied? Well, why we're getting denied in Medicaid may be very different than what we're getting denied for in managed care. Have we done the pre-authorizations correctly? Does our system hold the pre-authorizations in a way so the clinicians can understand how many visits they have left? Those types of things. Who does the TPRs if they're, how often are they done? Are they done correctly? Are they done timely? So it's really important to understand what the denial codes are, because the less denial codes you get, the less rework is done, and the more cash that comes into the agency, the higher your collection rate. So again, responsibility has to follow. Who is responsible for reviewing the denials? Who looks at denial codes? And again, this has to be matched with the ability to do something about it. You can have whatever person you want. You can have, the receptionist review the denial codes, but that's not going to get you where you need to be with this. Denial codes are very important to be looked at, to have meetings with. So your billing manager should be meeting with for example, your director of finance to say, wait a minute, I have all these denial codes. This is the reason why I think they're happening, and I need to get them out. Again, you're tracking this longitudinally. So if you have 100 denials for last week, and that's 3 times or 4 times higher than you're used to seeing, why is this happening? If you have 100 denials, how do I get that down to a much lower number where I don't have any denials, or where I have a very, very limited number of denials? If you do this on a weekly basis, if you understand the reasons for your denials and you read your denial codes, pointing back again to something like MDON, for example, it will tell you exactly why you're not being paid. It'll say the provider rejected for X, Y, and Z reason. And then you can go in and look at that and then correct the claim. Some softwares allow you to correct the claim in the intermediary, or you can correct it in your own software. That's a decision each department has to make. What's easier to do it? But nowadays, with these electronic claims, you can correct claims at certain levels, and it's all dependent on what's easier for your organization to do.
And Dewey, we had another question come in, and I think it goes, it ties into the addressing billing errors in the sense of, you were saying that both in-house and contracted services often come across billing errors, and people need to gauge what's best for them. So what is the benefit of having an outside billing service versus an in-house billing service? Can you kind of talk to that briefly?
Sure. When you outsource your billing department, you're outsourcing your billing department to a place where you have certain expectations. And again, you say to the billing department, or to the outsourced billing provider, these are my expectations. Here is my RFP, and they have to answer your RFP, and they will tell you, we'll be able to bill everything immediately. We'll be able to tell you immediately what was not billed out of your system. We'll be able to tell you what your denials are, and you'll be able to see who's responsible for fixing what things. The thing about outsourcing anything is if you have a dependable place to outsource, you no longer have to worry about sick days. You no longer have to worry about holidays. You no longer have to worry about vacations. They should be able to provide you the service, and that's their headache, to be able to provide the service to do that. Whether or not you want to do that is really a discussion, an internal discussion, an internal feel for the department or for the agency. The agency may feel that they really want to do their own in-house billing. We here at ICL do our own in-house billing. We feel that that's the way to go with it. We also feel that if we do this correctly, and believe me, we struggle with this every day like everyone on the phone struggles every day, but if we do this correctly, we're going to be able to drive down our denials, we're going to be able to drive down our errors faster than an outside billing company will. We feel that we'll be able to communicate, that we've set up structures to communicate effectively with our clinics, and that we'll be able to do it. So the balance that you see for an outside is A, it's a fixed cost. B, they have to bill whether there's holidays, sick days, hurricanes, or anything else, and you have to make sure they can do that, by the way. Where are they keeping your data? That's really a very, very large consideration. And are they HIPAA compliant, and are they really keeping your data someplace? Because if somebody hacks into them, you're responsible for it. So you have to be careful with that as well. Those are some of the considerations that I would offer.
And when you were talking about the RFP, Dewey, and the outcomes, Michael just asked, is there an industry standard for minimum FTE billing staff per 10,000 services a year or per $1 million billed per year, et cetera?
No. What you're going to do, I can tell you what it's dependent on. Again, it's dependent upon the task that you expect your biller to perform. It's dependent upon the software you use, and it's dependent upon how well your organization, how long your organization has been doing the billing. An organization that's mature in its billing with the same software over a number of years may need less people than an organization that's just starting out or an organization that's changing the software. So it's really important that when you take a look at this and you look at your financial viability of your clinic and you put your billers in there, you see how that balances out. You also know what the workload is. Can the biller perform the workload you have an expectation to do each day, or does the biller have to come in the next day knowing that they have to do yesterday's work? That's an important discussion, and that's why there's a billing manager involved in this, so that the workload that's given to the biller is appropriate and the biller can perform. Again, if you're not being able to bill out each week of the services that are provided in the clinic and you just can't get to it, and you said, okay, we're going to bill on Tuesday, but now it's Thursday, and you haven't even billed last week's, you may be understaffed. Again, you can do the math very, very easily and look at this. If you pay a biller, whatever you pay a biller, whether it's $35,000 for a biller or $40,000 for a biller, you can see how quickly some denials add up to the $40,000. These folks could be justified, and the way it's justified is by saying, my allowance percent is 92%. So I collect, my allowance percent is 8%. I collect 92% of my claims each year. If I go to 93%, I then have an extra $100,000, for example. Hey, look, if I hire a biller, that's the only way I can get to 93% is hire another biller or hire another review person or hire another supervisor person. So that's the type of analysis you do. Number one, you see the financial viability overall of the clinic. Number two, you start looking at your denial rates and you look at your uncollectible amounts to see if you can move that down. And number three, you look at volume to see if the volume that's being done is going to be going up or down. And number four, you look at your software system to make sure that you'll be billing in the same type of way you've been billing. The other thing to be really important that should be noted is when you bill things out on your financial viability of your clinic, Medicaid pays a full rate, for example. Medicaid managed care pays a full rate. But once you get into commercial insurance that are paying you $60 a visit and it costs you $125 to do the visit, that's another discussion for the finance folks, not for a billing and collection deal, because you're contracted at $60. So you may want to look at that as well to be able to afford a new biller if you need one. So we just wanted to give you an idea of some of the benchmarks. And when we say benchmarks, it would be really great if these were data dashboards. I'd love to come in the morning and be able to look at these, turn on my computer, and see what these are for the last week or so. So data dashboards are really based on outcomes. What are the expected outcomes of the billing department? And we've talked about this for the last hour, 18 minutes and 12 seconds. The critical indicators to consider, again, are the amount billed. In other words, how much do we bill out for the week? How much do we collect? How much are we billing by payer? How much goes out to this managed care company, that managed care company? How much goes out to Medicare? How much goes out to Medicaid? What's our average rate billed, and to see what that is? How much is getting rejected by insurance companies? What do we write off? What's denied? How much is being denied by payer? You may want to look at that. If you have denials by a managed care company, for example, or by Medicaid, what's really going on? Are they just not paying? Are they just ignoring the claims? And what are you doing about it? Again, if you do this on a week-by-week basis and you compare week by week, you'll immediately see, and you compare it to what you budgeted, you should be able to do a budget for the year, you'll immediately see any anomalies that are happening. You'll immediately see any disruptions in your collections on this. So you want to set up your benchmarking indicators, really want to be your outcomes, your approved outcomes, and they really should pop someplace in your system on a weekly basis.
So Thank you, Dewey. I think that's kind of the large part of the billing content we're going to get into today. But again, we encourage you to keep the questions coming. And we do have a couple more content slides. We're just going to go to a few polling questions right now. So have you ever heard of or been exposed to a change initiative on improving your billing collection practices in your current agency? Yes, no, or unsure. And if yes, in your opinion, did it result in improved revenue or improved client outcomes? And I think the rationale here, as Dewey had pointed out earlier, is if the billing department and the finance department really does its job well, that really allows our providers and therapists to provide the service they need to and keep the doors open for the clinic to continue providing the services they need. So we're curious to get your feedback. And again, we also want you to continue sending those questions our way. We're getting a lot of great questions and are happy to answer it in the 10 or so minutes we have left. And we're going to keep the polling open for about 10 more seconds. And then, Ev, I think once we hit about a minute, why don't we shut it down? Great. So we're going to have those questions come up soon. Always takes forever to load when you're on a webinar live. Okay, great. So it looks like about 23% of you have had change initiatives devoted to improving your billing collections practices before. That's fantastic. 11% of you have not, and 6% are unsure, and then about 60% didn't answer. And if yes, in your opinion, did it really make a difference? 21% of you said yes, and that's great. And it looks like the only other 4% who answered felt like they were just unsure of the results. So, for those of you, for the 10 people on the line who said yes, we would love to hear a little bit about what the experience was like for you when you were exposed to this change initiative, whether you were leading it or participating in it. So what we're really hoping over the next few months with CARE and with the calls that you're going to be participating in, as facilitated by Donna or David, is that you're really able to take the content we talked about today, go back and process it with your teams and figure out what pieces of it do you want to bring back to your agency. And we hope that your cohort calls are really a support group for you to be able to implement these changes over the next few months. We know these changes will take a long time, but at the same time, we also believe in kind of quick iteration and helping you move through cycles of change. So the next few months will really be helping you to take those first steps on that change initiative. So if any of you want to kind of chat any of your experiences on the right, that'd be great. We're going to take a couple seconds to let anything come in, and then we're going to move on to finish off the webinar. So do we have any recommendations for dashboard software? As a software that Aaron is using does not have dashboard capabilities.
Again, it all, thinking about data dashboards, it all depends on your software, what you're using, and it depends on how you can export the data. If you do a search for data dashboards, Google it, you'll find a whole listing of software of things that can be attached. But it really goes down to your IT department and asking the IT department how you can do this. And again, it goes to the organization. The organization should be devoted to outcomes. And how do you measure outcomes? And the answer is through dashboards. So there's probably an initiative going on in almost every agency these days to generate dashboards. So there may be one going on in your agency. So I would ask, through the finance department and see if one is going on. But you can Google or you can find software that you can upload charts to or upload reports to that will immediately give you data dashboards, things like Tableau and things like that. And you'll be able to use even a pivot table in Excel if your software can export to it. But I wouldn't be surprised if there wasn't a dashboard initiative going on in your agency.
I think you're right. From other clinics I've talked to, Tableau and Excel do seem to be two options that they consistently use as well. Okay. So if nothing's coming through, we're going to just move through the rest of these slides and get you out by 1 today.
Yep. And so we have about 5 minutes left, I believe, in this, give or take, 4 minutes or so. So we're going to go through this very quickly. These are all things that we discussed. Again, clear organization chart, great job, put the job responsibilities down that conform to the job description. Make sure your staff is properly trained, really, really important, and make sure your staff is evaluated. They want to know what they're doing. An evaluation is not draconian. Evaluation is there to help people do the job that you've asked them to do. Your reports really have to be clear. Your reports have to be generated each week, and you have to be able to have them available to go over them. Whether they're reports, whether they're dashboards, whatever they are, you should be able to get them every single week at a certain time and make that time in your schedule to go over that. Your dashboard indicators, like I said, can be reports, or they can be the goals, or they could be the outcomes that you've established. And again, a system for identifying the changes that you need to do. And when we say system, like I said, if you're going to change something, make sure that you sketch it out, make sure you flow chart it out, and make sure you walk through it. I can't emphasize that enough. Walk through it to make sure it works. And then again, barriers. Barriers to collection and eliminating those barriers. What are those barriers, and how do I talk to people to eliminate those barriers? How do I communicate effectively to get those barriers out of the way? So if you want some tips that we put here, take a look at this. You probably have your own tips in your own organization of how you want to change things. It's really dependent on the organization culture. It's really dependent on the personalities of the people involved, on what you want to do. However, there are some basic rules you want to follow. Don't try to change a whole bunch of things at once. It doesn't work. All you do is get further away from the goal line. It's really important that you identify your main change that you want to do, identify the task that it would take to get there, and move it towards the goal line. And then you can say, this is done. I see lots and lots of projects, either in our organization or other places, where they move, the project moves and just doesn't get to the end. It's 90% of it's complete, and it doesn't get it completely completed to make life easier. So make sure you do one at a time. Make sure you can jump up and down, and of course, celebrate your wins. Always celebrate your wins. Really, really important. And here's some, and just read those tips. You can read the tips as well as I can read them to you.
And I think we got in 2 comments from our earlier question, Dewey, that kind of really correspond with this. One from Michael was talking about how, the issue is for sometimes if people only do brief initiatives that are not, that are maybe short-term or partial, not done although complete, it doesn't result in sustained kind of results over time. And Andy made a great kind of comment as well, is that, while they've noticed in their organization improvements have been made and they keep continually billing more accurately and efficiently, it's such a complex process involved that it needs to be a continuous change process, and that kind of the process never really ends.
Let's hope not. We can always do something better today than we did yesterday, and that's a challenge. That's a challenge we have. And again, in the not-for-profit world, we have limited resources, so it's really, really important to make sure we're using the resources effectively, efficiently, and that we understand that we can change things and move it forward.
So this is our last question slide. We're going to move through the rest of the slide, but if you have any last-minute questions you want Dewey to answer, please chat them in, and I'm going to move through some logistics for the rest of CARE briefly. So thank you for attending this webinar today. We do have a series of other webinars that are upcoming that if you're not in the billing cohort, you do not need to attend, but we are offering them to all CARE clinics, and I'll go over that in a second. But the next step for the billing cohort on the line, the next step is your calls, and that will be scheduled very soon. Thank you for filling out the call availability, and I think we'll be sending that invite out shortly. But just a little bit of overview of what to expect. We're going to have you reintroduce yourself briefly again, explain why you're here, what is your problem, issue you're probably trying to solve in your billing and collections department, talk about some ground rules for the calls and just the call schedule going forward, discuss this webinar and our face-to-face meeting and talk about strategies that you want to implement, and we want you to come prepared with data. So do you know what your current collections rate is by payer mix? And what do you want to change about these numbers through the rest of the initiative and also sustained going forward? The remainder of the calls will be in a format of that all of you who attended the face-to-face should be familiar with in terms of the role play we did, where each clinic in the cohort will be given an opportunity to present the key problem or implementation process they're going through, take advantage of the other clinic's expertise for brainstorming solutions, and really kind of use that as a kind of a sounding board for all the different changes that you're hoping to plan. We're going to set the presentation schedule randomly, and you'll find that out before the first call. And we just want to stress that since, you know, your cohort really is your resource team, we really ask you to make sure that you have members of your team attend these calls and also actively participate. I think we saw great participation today on the webinar, and we're hoping that continues going forward. I think all of you on the downstate cohort have received an invite to a listserv that you can use to communicate with the group. I know Sarika already sent out a resource for how to get more interns to help you with your team, so I really suggest that you check that out. And for those of you on the line who are in different cohorts, you can be expecting to get this invite soon. And we hope that this is your resource for any questions that you have. And for any kind of larger content questions the listener can't answer, Lauren, who's on the line here as a panelist, and who I think most of you have met, will be your resource contact to help identify further resources. Data collection very briefly. This is kind of your indicators collections rate by payer mix. We're going to collect it at the midpoint, so halfway through the calls and at the end of care. It's going to be collected via Qualtrics link, and it'll be rapid feedback. So we'll collect it from you, and we'll present it right back, similar to what I think you're doing in your own clinics with these regular reports. So I'm not seeing any questions coming through, and I think we're a little bit over time, so we want to wrap up. But, you know, these are the upcoming webinars. You've gotten the emails about it. It's also on our website under the Care Resources page, password CTAC Forum. And, you know, at the end, just want to stress that please fill out the survey afterwards. We very much want your feedback and hear how this webinar went for you so we can continue to improve. And Dewey, any kind of concluding comments or wrapping up?
No, thank you for being with us this morning. It was a pleasure, and please feel free to ask any questions after the webinar and send it to CTAC, and we'll get back to you. Have a great day.
Great. Thank you, everyone. Have a great day.